Okay, we move into chapter 35, which is environmental emergencies. Kind of the concepts we're looking for here are the effects on the body, the assessment and the care of hypothermia, as well as cold injuries, and then as well as exposure to heat. And then we're going to also look at the signs and symptoms and treatment for drowning and other water-related injuries, as well as bites and stings, and as well as high-altitude illness. When you go through some of this chapter, you're thinking probably, why does this pertain to me? If I'm learning about this here in the state of Illinois, just remember that we got to teach you to the national curriculum, because you can take your license and practice in any state across the country. So these are the national guidelines, so that's why we treat some things even if they don't make 100% sense for why you're learning them for where you live. Environmental emergencies can occur in any setting, wilderness, rural, suburban, and urban areas. You can have cold exposure in warm climates. You can have warm exposures in cold climates. Things like being inside, say, a refrigerated truck or something, and you go down, all of a sudden now you're in that cool environment too long, so it can create a cold emergency even though you might be in a warm environment. So these are going to include exposure to both heat and cold, drownings, other water-related injuries, high altitude bites and stings, from anything from insects to marine life. The key to effective management are going to be to recognize the patient's signs and symptoms, provide prompt and proper emergency care. However, you must also recognize that exposure may not be the only danger to the patient. Environmental emergencies can involve pre-existing or cause additional medical problems and/or injuries. So it's important to provide a good assessment to the patient, and then it's important to understand their signs and symptoms and treat them appropriately for what you discover. Now, when we look at the different ways that a body loses heat, if the environment's too cold, the body heat can be lost faster than it can be generated. So the body's going to attempt to adjust for these by using its internal mechanics, basically, to try to correct the problem. What's important is to understand the different ways that you can lose the body heat. So the first one they talk about here is conduction, which is the transfer of heat from one material to another through direct contact. That's going to be called conduction. Heat's going to flow from the warmer material to the cooler one. One of the bigger issues here is with water chill, because the water conducts heat away from the body 25 times faster than does air. So patients with wet bodies and clothing are especially susceptible to water chill in cold environments. The next one we're going to talk about here is convection, and that's when currents of air or water pass over the body carrying away heat. That's going to be called convection. The effects of a cold environment are worsened when moving water or air surrounding the body. Wind chill is a problem, and there's a good graphic in your book on the wind chill and the effects it has and the exposure time, things like that. So that's going to basically, the faster the wind speed, the greater the heat loss. Third thing we talk about here is going to be radiation, and that's in conduction and convection. Heat is picked up by the surrounding air or water. In radiation, the body's atoms or molecules send out rays of heat as they move and change. If you were in the vacuum of outer space with no air or water around to pick up heat, you would still lose heat by radiating it out into space. So most of the radiant heat loss occurs from a patient's head and neck, because the other parts are usually covered. You'll also talk about this when you go through the OB chapter, that the fastest place a newborn's going to lose body heat is going to be through their head. That's why you want to cover it after they're born. So that's just another concept to kind of think about when you're thinking about radiation. Two more to talk about here. Evaporation is going to occur when the body perspires or gets wet. So as that perspiration or water on the skin and clothing vaporizes, the body experiences a generalized cooling effect. So again, this could kind of be more emphasized if you're sweating in a cool environment. With the convection method as well, it's probably going to amplify things. And then the last thing that we're going to talk about here is respiration. So you actually have a loss of body heat as a result of exhaled warm air. Kind of the amount of heat loss depends on the outside air temp as well as the rate and depth as your respirations. So generalized hypothermia is going to be when the cooling affects the entire body. Um, so this is going to be when you have exposure to cold, reducing the body heat, and then the body is unable to maintain the proper core temperature. It is kind of a progressive issue that can eventually lead to death. There's a graph in your textbook under table 35-1 that kind of breaks down that process, and as the body temperature drops, kind of the symptoms and what you're going to see. Now, there are some predisposed factors that are going to enhance the rate of cooling of the body. So things like shock, because obviously you have some sort of issue going on in the body already. So the body's already struggling to maintain its natural environment. So now when you expose it to cold, it's going to enhance and speed up that hypothermic process. Injuries, infections, and immobility is going to also be a predisposed factor. Diabetes with hypoglycemia. And then they found that patients that are under the influence of drugs or alcohol are also predisposed to this issue. Now, sometimes you're going to have obvious signs when you arrive on scene that they've been exposed to hypothermia, but sometimes it's going to be subtle. So here's kind of a small sampling of different conditions that you might want to consider. Has this patient been exposed? Could they be hypothermic? First one being just alcohol ingestion, and kind of what you're thinking about here is not so much the alcohol ingestion itself, but did they pass out on a cold floor? Have you ever been down in your basement in the middle of summer when it's super hot and think, man, this floor feels really good on my feet because it's nice and cool? Well, if you have an intoxicated individual that passes out on that cold floor, it could make them susceptible to perhaps becoming hypothermic. Do they have any underlying illnesses? So do they have any circulatory disorders or other conditions that would increase their susceptibility to being cold? Next one would be overdose or poisoning. And again, this kind of falls back like the alcohol ingestion. So what kind of environment were they put in when they had the issue? Major trauma, again, kind of the similar situation here. What kind of environment are they in? But with this one also, is there any signs of shock that could potentially assist in the hypothermic process? Outdoor resuscitation. Is your patient getting too cold? If the patient's a drowning patient that's been in the water, has exposure to the cool water caused hypothermia. So it could be extremely warm outside, but if they're in a pool that's in the mid 60s for a temperature, then that makes them more susceptible for hypothermia. And then the last one is going to be decreased ambient temperature. So room temperature. Is your patient living in conditions that may be too cold for them? Especially with older adults, their circulation isn't as good anyway, so they're more susceptible to hypothermia. But these are also the people that are on fixed income. So when you go there in the wintertime, they might be inside, but in order for them to afford their bills, they might have to have their furnace set at, say, 60 degrees. So are they in an environment that potentially could cause this hypothermia? And then here's the geriatric note, just kind of covering what I talked about there. That their body systems are going to make them more susceptible to hypothermia, and then you put them in an environment with the slowing body systems, and it can lead to hypothermia. Now, a pediatric note with this is going to be that infants and young children are small, but they have a large skin surface area in relation to their total body mass. They also have, generally speaking, less body fat. So these two things together are going to make them more prone to hypothermia. They're also unable to shiver nearly as much as an adult due to the smaller muscle mass. So pediatrics, geriatrics are going to be the two that are most susceptible to hypothermia. So what are we looking for with hypothermia? Early stages, you're going to be looking for shivering. So everybody should know what shivering is. It's kind of when the body just shakes, but it's not a seizure. Numbness or reduced or lost sense of touch. So it'll start basically as kind of the numbness phase, and then they'll kind of go to a pins and needles phase, and then they'll completely lose sense of touch to a hypothermic affected area. Stiff or rigid posture can occur in prolonged cases. Drowsiness and prolonged exposure, the patient may become irrational and drift into this drowsiness, altered level status, or they might actually start removing their clothing. Rapid breathing and pulse, slow or absent breathing and pulse in prolonged cases. Blood pressure may also be low or undetectable in these patients. So these are a few of the things that we're looking at. We got one more slide to talk about with it. Patient may have loss of motor control. So for example, poor balance, staggering, basically just an unsteady gait that they're going to need assistance just staying upright. They may have joint stiffness or muscle rigidity. They may have that decreased level of consciousness or unconscious. They may have this glassy stare, kind of like the lights are on, but nobody's home. They may have cool abdominal skin. So place your hand inside the patient's clothing with the back of your hand against the patient's abdomen, and just kind of feel if it feels abnormally cool. And then the last one here is going to be red skin, but it may also be pale or cyanotic for prolonged cases. So early red skin, late pale or cyanotic. Now talking about ways to rewarm your patient. So the first one here is actually going to be called passive rewarming, and that's when we allow the body to rewarm itself. So you're going to want to do things like cover the patient, remove any wet or abnormally cold clothing, and then just blankets and blankets to kind of let the body warm itself back up. The second thing is going to be active rewarming, which this is going to be when we include application of an external heat source to the body. All EMS systems permit passive rewarming, although some allow the active rewarming of a hypothermic patient who is alert and responding appropriately. Just really follow your local protocols with this, because there are pros and cons to doing things both ways. So you have to follow what your guidelines are. The first patient we're going to talk about is one that's alert and responding appropriately. So what's the care for this hypothermic patient? Well, the first thing is going to be to remove the patient's wet clothing. Try to keep the patient as dry as possible. So either get them dry clothing or wrap them in warm blankets. Try to keep the patient still and keep them in a warm environment. Don't let them return to the cold environment. Do not massage the patient's extremities. The next thing that we're going to do here is actively rewarm the patient during transport. So this is going to be things like applying heat to the patient's body in the form of heat packs, hot water bottles, electric heating pads, warm air, radiant heat, or even your own body heat. So again, your body might be warmer than theirs. So if it's a close person that you know and they're hypothermic, literally like you've probably seen in some different movies, bare skin to bare skin, and then you can warm them up that way. Use caution when you're actively rewarming the patient because you don't want to cause a burn. Sometimes the commercial hot packs can get pretty hot, and if you just take that and throw it directly on the skin, yeah, you're going to warm the area up, but you can also cause a burn potentially. Always be ready to provide care for shock. And then if the patient's alert, you can give them warm liquids, but you need to give them the warm liquids at a slow rate. If you give it too fast, the patient's circulation patterns can actually change. Transport the patient under most circumstances within reason. Remember, you can't kidnap a patient, but these patients you should always be recommending to be transported. Try to get them to go to the hospital unless it's a very mild case in which they're just exhibiting maybe shivering as one of their signs. And then in that case, if you get them warmed up and they're completely conscious, alert, and oriented, and they want to refuse, it would be one of those that you could allow it to happen. Now, with extreme hypothermia, the patient can be unconscious and you may not be able to really find vital signs. The body just kind of everything gets slower and slower and slower and slower when it comes to hypothermia. So the heart rate can actually slow to as low as 10 beats per minute before it would completely shut down. These patients are going to be, it's going to be like you're feeling an icicle when you touch them. If there's no pulse, if you can't find a pulse, start CPR, try to get an AED on as quickly as you can. And if the pulse is present, care for the patient who is unresponsive or not responding appropriately. There's an old saying in the world of EMS that says you're not dead until you're warm and dead. And it is a true statement. So if you say you go out on a drowning, even if they've been under the water for a significant amount of time, if their body temperature has slowed down and gotten low enough that it basically shuts the body down, there's a very slight chance that you could actually still save these kind of patients. They're few and far between, but there are stories out there of people that have been underwater for a substantial amount of time. They come up, they're in a hypothermic state, the body has basically shut itself down, but for whatever reason has not died. And then through the resuscitation process, they've actually been able to get them back. Basically, if you get to a cardiac arrest, make sure that the patient's not hypothermic. If they are, give them every chance. You can't make a patient more dead, so it doesn't hurt anything by trying on these people. So go ahead and give them a chance, try to run the cardiac arrest, and then look to your medical control for direction with it. Now, caring for that hypothermic patient who's unresponsive or responding inappropriately. First and foremost, remember your ABCs and ensure that the airway is open. If it is open and you're able to provide high concentration O2 that's been passed through a warm water humidifier, it's going to promote internal warming in addition to increasing the blood oxygen level. If it's not available, either use your local protocols or get medical direction involved so that they can give you some assistance in whether they want you to administer O2 or just use the ambient air. Oxygen demands are considerably lower in severely hypothermic patients, so ambient air may actually be the best bet. Next thing here is going to be to wrap your patients in blankets. If available, use insulating blankets, but make sure you're handling these patients very gently. When they get to this state, they're going to be more susceptible to ventricular fibrillation. So something as little as jostling the patient around can actually throw the heart into that arrhythmia. Don't allow any of your patients with an altered mental status or unresponsive to eat or drink anything. Obviously, if they're in this state, you'd have to be concerned about if they eat or drink anything, does it become airway issue because they're not able to get it down like they're supposed to. These are patients that you want to transport immediately, so get them safely into the ambulance. Rapid transport, consider the need for ALS because they can also have the ability of rewarming the patient through intravenous fluids. Local cold injuries and frostbite are going to be injuries that are going to commonly affect just a small isolated area. Most commonly, these are going to be the ears, nose, face, hands, fingers, and feet and toes. Sometimes it'll be obvious and the patient will know, but sometimes you'll get to a patient, they'll say they're fine, but it's because they may not understand that their toes inside of their boots have basically frozen off, and they haven't looked at them. So this is where assessment is kind of key. And it's basically going to occur because the blood flow is limited by the constriction of the blood vessels, and then that causes the tissues to freeze, and they may form ice crystals. Now there's a couple different stages to this. The early superficial stage, what's called frost nip, is going to be early on. And what you want to do is remove this patient from the cold environment and then cover the affected area. So you want to warm the affected areas. If the injury is to an extremity, splint and cover it, but do not rub or massage the area, and do not re-expose it to cold. The second stage here, which is going to be the later stage, is going to be frost bite. And the way we're going to treat these is going to be first, if there are signs of hypoxia, and the patient's vital signs would indicate, then you want to use oxygen therapy. You want to cover the frostbitten part, and you want to handle it very gently. You want to transport these patients to a medical facility without delay. If transport is delayed, make sure to get them indoors or into a warm environment. Don't allow them to drink alcohol or smoke, because that's going to cause more constriction of the blood vessels, which is going to decrease circulation, and it may actually make the condition worse. Rewarm the frozen part as per local protocol, or always get a hold of your medical director. Look for some assistance in this. We live in the environment where I can assure you every one of you has at least had frost nip at some point in your life, so you should understand a little bit on what to do. If the area is cold, get them out of the cold. So active rewarming, which we talked about, is where you're going to use an external source to try to warm the body. It's seldomly recommended with frozen parts because it increases the chance of permanent injury. So you're only going to want to do this in the situations where your protocols dictate it, or you contact medical control and they give you direction, or if your transport's going to be severely delayed and you cannot reach medical direction. Hopefully, 99% of the time these days you're going to be able to reach medical direction, but in that very rare instance, then it may be a time where you will have to do rapid rewarming. Basically what it's going to entail is warm water, and we'll talk a little bit more about this on the next couple slides here. But warm water is what you're going to need, and a container in which you can immerse the entire site of injury. So if it's to their foot, you need to make sure that their entire foot can be encapsulated in the water, but you do not want the affected area actually touching the sides or the bottom of the container. The water that we want to get with this it needs to be between 100 and 105 degrees Fahrenheit. Preferably, if you don't have a thermometer, basically you should be able to stick your finger into the water without experiencing any discomfort. Kind of err on the side of caution here. Better to be just slightly cool than entirely too hot for this. But you also need to make sure that it's not too cool, because then you're not actually going to be rewarming, and potentially you could be exasperating the problem. You want to fill your container with this heated water, and then you want to remove any clothing, jewelry, basically anything on the affected area that could become an issue as swelling occurs. You want to fully immerse the injured part, but you want to make sure that it does not touch the sides or the bottom of the container. With that, understand that what happens when you put ice cubes into your warm soda, it cools the soda down. So as you immerse the body part in there, it's going to cool that water down. So as that water cools, you may need to remove the body part, remove the water, put new water in, and then it's just kind of a cycle. Make sure you're kind of stirring the water around so that it can stay as close to that 100 to 105 degrees Fahrenheit as possible. So continuing here, we're stirring that water like we talked about. Understand that your patient may have pain with the rewarming process, and this is actually a good indicator of successful rewarming. If you completely rewarm the affected area so it's become red or pink again, gently dry the affected area, and then you want to apply dry sterile dressings to the affected area. Now if it's their fingers or toes, you want to make sure to place some of those dry sterile dressings in between the fingers to keep them from sticking together, and then you want to dress the entire hand or foot around that. You want to try to keep this patient at rest. Don't allow the patient to be up walking, especially if the frostbitten or is a lower extremity that's been rewarmed. Make certain that you keep the entire patient as warm as possible. Hopefully you've been able to remove them from the environment, but use blankets, use warm blankets if you have them. Make sure that your blankets are not directly touching the affected area. You want to make sure that they've been dressed with those dry sterile gauze like we talked about. Do not allow the limb to refreeze. Continue to monitor your patient, continue to reassess your patient, continue to check vital signs on your patients, and then transport these patients as soon as possible with the affected limb slightly elevated. Now we're going to move into exposure to heat and the effects of heat on the body. So this is going to be when there's heat that's not needed for temperature maintenance, and then that heat's not lost. It creates hypothermia, so it's when your body temperature increases above normal. If left unchecked, it can lead to death. So think about children that are left in a hot car and how that eventually leads to death for them. But it could be anything from athletes to people working outside. And for us living in the Midwest here, the previous section on hypothermia is very pertinent because we're going to see it all winter long. But it also gets extremely hot through the Midwest. So we're going to see these heat emergencies and hypothermic emergencies of our patients too. So heat cramps and heat exhaustion are going to kind of be the earlier phases of this, and you're going to see moist, pale to normal to cool skin color. Heat stroke, you're going to see the patient's going to have a hot, dry, and possibly moist skin. Similarly to the wind chill index that we talked about in the last section, there's also going to be a heat index, and that's going to be located in figure 35-5 in your textbook. So it takes into consideration the humidity and then the actual air temperature. And then the more humidity that there is, the warmer it's going to feel. So if it's 100% relative humidity on a 90-degree day, it's going to feel like 132 degrees out. So these are the days where heat exhaustion and hyperthermic emergencies are going to affect a little bit faster. The first one we're going to talk about here is known as heat exhaustion. So these are going to be the patients with moist, pale, and normal or cool skin. And basically, as sweating continues, the body loses salts, and basically the patient is going to start having muscle cramps as a result of this. Healthy individuals may experience a form of shock brought about by the fluid and salt loss, but it really just varies depending on the exposure, the time of exposure, exactly the heat of the exposure that they're in, any pre-existing medical condition. There's some variables. Not everybody's going to react the same if put in the same environment. So what are we looking for as we assess these patients? We're looking for muscle cramps. We're looking for weakness and exhaustion. You may see rapid or shallow breathing. You're looking for a weak pulse. You're looking for heavy perspiration in these patients. And then potentially there could be loss of consciousness, but it's usually brief. So syncopal episode is a possibility with this as well. And then what are we going to do for these patients? First and foremost, with any environmental emergency, remove the patient from the environment. So in this situation, remove them from the hot environment. Even getting them to a shaded area is going to make a significant difference. But if you can get them into an air-conditioned area, such as your ambulance, it's going to expedite the process. If there's signs of hypoxia or the potential for shock, always consider the usage of oxygen. Loosen and remove clothing and cool the patient by fanning. But you need to be a little bit cautious with this because you don't want to cool them too fast that you cause shivering. Put this patient in the supine position and then keep the patient at rest with it. You can give these patients small sips of water. However, you need to be a little bit concerned about the potential for nausea or vomiting. So if they start getting nauseous at all, withhold water, don't give them anything, and then you need to be prepared for the vomiting. You need to be prepared for potential airway problems with these patients as well. If their patients having cramped muscles, you can apply cool, moist towels over them. Again, you don't need to make it freezing cold. You don't want to cool the area faster than what you should because you can cause the patient to shiver and you can cause other issues. And then transport the patient. Again, if the patient's conscious, alert, and oriented ×4, they have the right to refuse. So what's kind of our decision point here? This is where you're utilizing your skin assessment. So what's the color and condition of the patient's skin? And that should help you dictate whether, yes, they can refuse, or, hey, I need to talk this patient into going to the hospital. Now we're going to move into those patients that have hot skin, whether it's dry or moist, and we'll talk about why here in a second. But heat stroke, you need to understand, is a true medical emergency. If it's not corrected, it can lead to death for the patient. And heat stroke is going to be when the temperature regulating mechanisms fail, so the body's not able to rid itself of the excessive heat, and the body temperature would keep climbing and climbing, and then it will eventually lead to death. Like we talked about, there are some areas that are more susceptible to this. Individuals working outdoors that don't understand when it's time to take a break or time to stop. Children and elderly, especially if they're in poorly ventilated areas or areas without air conditioning. And again, this could be those elderly patients on fixed incomes that can't afford to run their air conditioning. So it may be just a matter of they're in their apartment and it got too hot in there. And then, of course, the one that you always hear about in the news is the children that are left in cars with the windows rolled up. Now, like I talked about, whether the skin is dry or moist, initially the patient's going to sweat. Now, as this progresses, the patient will actually stop sweating. The issue with that is sweating is your mechanism to lose heat through evaporation. So once you've stopped sweating, you can no longer lose the heat through the evaporation. And then it's going to kind of exacerbate the issue and cause your temperature to climb perhaps a little bit faster. So if you're ever outdoors in the heat, once you stop sweating, you've kind of hit the danger zone. So when we look at our assessment, what are the things that we're looking for with this scenario? First one, loss of consciousness or altered mental status. An altered mental status must be present for a determination of actual heat stroke. Your patient may have rapid or shallow breathing. They may have a rapid pulse. They may have generalized weakness. Like we talked about with the perspiration, they're going to be sweating initially, and then as this progresses, there may be little or no perspiration. Make sure that you're assessing the pupils on these patients because you may find that their pupils have been dilated. And there is the potential for seizures in these patients in the absence of muscle cramps. And then what's our care for these patients? Like we talked about, first and foremost, in all of these scenarios, remove your patient from the environment. So in this situation, remove them from the hot environment. Get them into your air-conditioned ambulance, or at a minimum, get them into a shaded area so that the cooling process can start. Remove the patient's clothing, and then you can apply cool packs specifically to their neck, groin, and armpit areas. This is going to be the fastest way to get the cooling process to occur is by utilizing these areas. For infants and young children, you can actually use tepid or lukewarm water, and then with medical direction, as the body starts to cool, you can replace it with cooler water. Keep an eye on their airway. Administer high concentration oxygen as needed or as directed by medical control. Transport these patients immediately. If it's delayed, continue to attempt to cool the area with ice packs. Keep them in a cooler environment. Whatever you have to do to try to get the body to cool. Kind of just reflecting here a little bit on the dangers of extreme body temperature. So as the body temperature decreases, the first thing that's going to occur are the muscles are going to start to shiver. With that, the heart becomes irritable and it becomes more prone to dysrhythmias. Kind of the critical number is 91.5 degrees Fahrenheit. Once the body temperature reaches this point, electrical activity to the brain is going to become more abnormal. So your patients are going to start having those altered mental status or perhaps become completely unresponsive. The central nervous system is going to also become more sluggish with this. Now, when it comes to patient's body temperature increasing, the first steps are going to be sweating leads to evaporation and cool skin. So a patient with cool skin means the body's still doing its job. It's probably maintaining that internal core temperature at least as close to normal as can be. But once the sweating process stops, the body loses the ability to lose the heat, and then if the excessive heat builds up, it can become hot. Kind of the critical point for hyperthermia is going to be 105.8 degrees Fahrenheit, and after this point is when you can have significant damage that can occur. Now we're going to move into the water-related emergencies. And again, for our area especially, is very pertinent because we have lakes, rivers, ponds, people have pools. Basically almost any of these can occur in our area. So anything from boating to water skiing, maybe not so much windsurfing in our area, but again, national criteria, so you need to understand it. Jet skiing, very prominent around us, and then there actually is diving, and then scuba diving does occur around us as well, even though you may think of scuba diving as more of a destination type thing where you're out in the oceans, diving for shipwrecks or diving to look at reefs, things like that. But we do have scuba diving around here as well. So what are some of the key assessment findings that we're looking for? First one's going to be airway obstruction. Most commonly it's going to be caused from water in the lungs, but you could have foreign matter in the airway or swollen airway tissues if there's been a neck injury. You may also find spasms of the vocal cords in some cases of drowning. We're looking for cardiac arrest, which is often a result of respiratory arrest that occurs during the drowning process. As far as signs of heart attack, don't dismiss chest pain as being cramping or something along those lines. If the patient's having chest pain, then you need to treat it as a potential cardiac issue because heart attack is possible. Injuries to the head and neck, especially with those found in boating, water skiing, diving accidents. Anytime that there could be trauma related to the patient that you found, be concerned about injuries to the head or neck. With that, you also need to be concerned about internal injuries. So make sure you're using your assessment skills as you're going through that, looking for the potential for internal injuries. You could also see generalized cooling or possibly hypothermia. Have you ever been in a pool in the middle of summer and when you got out you started shivering? Well, that was your early phases of hypothermia because it doesn't take an extremely cold temperature in the water source to cause these issues. So be looking for generalized cooling or hypothermia. Substance abuse, patients that utilize alcohol or drugs are at a little bit higher risk of in these water-related accidents. They attribute to 30% of the drowning patients if you read your book. So be aware and looking for substance abuse. And then the last thing is drowning patients, where you may discover them either under the water or face down in the water. They may be conscious without vital signs. But again, like we talked about, you want to give these patients every chance that have been in the water, if at all possible. So what is drowning? Well, according to the WHO, it's the process of experiencing respiratory impairment from submersion or immersion in a liquid. The outcomes may be death, morbidity, or possibly no morbidity, just depending on the situation. You may go on calls where patients have been successfully resuscitated through CPR, and it's a near drowning, but you still need to transport all these patients because of the potential for airway issues, for the potential of what they've kind of taken into their lungs, and there's a higher risk for infection and issues caused by this as well. The drowning process often begins as the person struggles to keep afloat. They may gasp in and start taking in water, and as they do and take that into their lungs, it's going to exacerbate the issue, and then it's just going to continue if they're not removed from that environment. Once they start to submerge, your patient may take one final deep breath, but then once they submerge, they can no longer get air into the system. Water will enter the airway, followed by coughing and swallowing, and then an involuntary swallowing of more water until basically you can no longer get air and your respiratory system shuts down. So once you've reached this point, basically there's a reflex spasm of the larynx, and that seals the airway. So your patient's going to actually become unconscious as a result of hypoxia. Some who die just die from the lack of air, but most will attempt the final breath, or they will become unconscious, and then the lungs will actually fill with water, shutting the system down. Like we talked about, usually drowning occurs in cooler water, so your patient may become hypothermic. The one positive to this is that they could be underwater or in cardiac arrest for a significant amount of time with the potential of still having a successful resuscitation. Now, they are few and far between, but the possibility is there. A little bit on rescue breathing, whether you're in or out of the water. First and foremost, do not delay transport. Once you get them out, begin rapid transport. Get them to the hospital for more definitive care. Begin the rescue breathing without delay. If you're in the water with the patient and they're not breathing, support the patient in the semi-supine position if possible and provide ventilations. Any ventilations at this point are better than no, so you may have to get creative in how you can administer these ventilations, but it's important to try to start them as soon as possible. One thing that you may encounter is some airway resistance. And so you may have to more forcefully ventilate these patients than you would other patients. And this may be due to, like we talked about, the larynx kind of shutting itself off as a natural body reaction, or it may just be that the lungs and the stomach have filled with water, and that's going to provide a bunch of resistance. So as you're trying to put air into it, the system's kind of already full. So you're going to see this resistance, and then you're going to have to do things a little bit more forcefully than normal. Now, if you get to a patient and the patient's unconscious or they have visible head injuries, assume that they're going to have neck and spinal injuries as well. So kind of err on the side of caution with this. Now, a little bit of common sense says that if you have to start resuscitation, it's life over limb. So go ahead and start the resuscitation before you immobilize the neck and spine. However, do your best to try to get those mobilized throughout the process once you have enough people there that can assist with getting all the tasks completed. Also, a little bit of common sense that you may or may not be able to complete an assessment with spinal injuries while they're still in the water. Again, first and foremost, get them out of the dangerous environment. In this situation, the dangerous environment is them being in the water. And once you get them out, then you can provide that adequate assessment for your patient. Again, do not delay basic life support. If there is the potential for a spinal injury, like I said, you want to take care of it, but BLS always takes priority. Whenever possible, try to keep the patient's neck supported and in a straight line with the body's midline. They actually make spinal boards that float. If you have this, you can actually immobilize the patient while they're still in the water, get them on the board, remove them from the water while they're on the board, and then go through your assessment or BLS at that point. Hopefully you're going to get information from the dispatchers so you understand what you're walking into, but it's also important to understand that information you give to the hospital, either from the scene or during transport, could be critical in these patients as well. Talking specifically here about diving accidents. Now this could be from something as simple as somebody diving off the side of a pool that was maybe a little bit too shallow, to diving off a diving board, getting to the bottom, to potentially being out in the river and jumping off some cliff walls or whatever the case may be and injuring themselves that way. Most of these are going to involve the head and neck, but do a full assessment because it could involve other portions of the spine, it could involve the extremities, it could involve the ribs. Kind of the moral to diving accidents is they're the same as the other water incidents that we've already talked about. Basically get them out of the water, care for them as we've talked about. Okay, a couple different scuba diving accidents scenarios that we're going to talk about here. The first one being an arterial gas embolism, and this is basically going to be when an air embolism enters the bloodstream from leaving a damaged lung. It can occur from a few different things. The first one being a diver holding their breath, but it may just be due to inadequate training, some sort of equipment failure with their scuba gear, or maybe they're trying to conserve air. The second potential scenario we're going to talk about here is decompression sickness, and this is going to result from the diver surfacing too quick from a deep, prolonged dive. So when they're breathing in the O2 from these tanks, they're a mix basically of 21% oxygen, I believe, and the remainder is nitrogen. And as they go deeper and deeper and stay longer in the water, these two gases enter the cells. And basically when they ascend too fast, it doesn't allow them to escape, which can cause this decompression sickness. Now this isn't like necessarily an immediate issue that shows, so there is potential. Let's say you had somebody that was vacationing and they went on a dive a couple days ago. They flew back home. Now they're home, and they're starting to show this sickness because it can take up to 48 hours to appear. Now, for these two things, what are we looking for as far as signs and symptoms? With the air embolism, you're looking for the potential for altered mental status. They may have a sudden rapid loss of consciousness. They may have blurred vision and or possibly seizures. Continuing with the air embolism, you may see paralysis or paresthesia within an extremity. There is the potential for stroke because any embolus can cause the potential for stroke. They may have numbness or tingling sensations in the extremities. You may find generalized or specific weakness, so specific meaning perhaps to a specific extremity. You may find frothy blood in the mouth or nose. The patient may experience incontinence, so they may be peeing themselves. They may have chest pain, and they may have stroke-like symptoms. A couple more signs for the air embolism. It can cause a myocardial infarction. If that embolus reaches the heart, it could basically cause a heart attack. And then you may see respiratory arrest or potentially cardiac arrest with these. Now, looking at the decompression sickness, you're looking for anything from altered mental status and related symptoms to fatigue, to pain in the muscles and joints, to itchy blotches or mottling of the skin. A few more signs and symptoms here. They may have numbness or paralysis. They may have choking, coughing, dyspnea, or substernal pleuritic chest pain. So substernal below the sternum, and then kind of in that lining around the chest. Now, it may be hard to distinguish if that's being that kind of pain or it could be a cardiac pain. So utilize your full assessment skills. Your patient may also have coughing. They may also have peripheral edema or swelling. Now, that was a lot of signs and symptoms there for both of those emergencies. The nice thing is that the emergency care are going to be the same regardless. So again, always airway, start with airway, maintain an open airway. If the patient is in need of oxygen or if medical control gives you direction to administer oxygen, then you want to administer the oxygen. Keep these patients warm. You want to patient them either in the supine position or on their side, and it doesn't matter which side, it can be either side. And then continue to monitor the patient. You may have to reposition the patient, especially if there's any sort of altered mental status. You want to make sure that you keep their airway open. Contact medical control for specific transport instructions. You may be in an area where one hospital can effectively treat this better than another. So if your patient is stable, they may divert you to potentially a hospital that's a little bit further away to get more definitive care. But then promptly transport the patient. And again, anytime that you have the need for ALS at the BLS level, go ahead and call for them. Now, if you're ever put in the situation of having to do the water rescue, there's kind of a progression through how you want to try to do the rescue. The first is going to be reach. Hold something out to the patient if you can't reach them, but a nice solid object that they can grab a hold of and that you can just pull them in. That's going to be the easiest and safest to do. If you can't do that, if they've floated too far away, it's the throw and tow method, which is basically going to be to throw an object that'll float, like a life ring with a rope tied to it. Allow them to get a hold of that and pull them back in. If neither one of those are an option and you have the ability, the next step is going to be row. And if you have the ability to get into a boat, row to the patient. If it's a boat with a motor on it, use caution as you approach the patient because you don't want to run into them or have the prop run into them where it's going to cause more damage. And then the final concept here is going to be go. which is going to be swimming to the patient, but this is going to be the last resort. Even if you're an excellent swimmer, you need to use caution because you don't know why that patient is all of a sudden in need of a water rescue. Maybe they're a really good swimmer too, and there's something that causes them to not be able to get back. So the example I would go with here is when I was much younger, we were visiting family out at the ocean. My very little cousin was in the ocean, and all of a sudden we noticed he had drifted out. His head looked like a little buoy out there, popping up and down over the waves. My brother, who was a teenager at the time, decided he was going to go out there to get him. He swam out there, not knowing that the reason my cousin had gotten taken out there was because of a riptide. Well, my brother obviously wasn't a good enough swimmer or trained in how to swim with the riptide as well. So now he got pulled out there. So the lifeguards ended up having to bring them both back in when it was all said and done. So that's kind of why the swim to the patient is a last resort, because if you've not been trained in the situation, you don't know what you're necessarily getting into. A couple slides here to talk about ice rescues. And with everything in EMS, the number one rule is who's number one? You're number one. Make sure to protect yourself. However, there are some ways that you can reach the patient. The first one being throw them a flotation device to the patient, preferably with a rope on it so that you can pull them back in from that. But even if all you have is a flotation device, get that to them so that they can at least stay buoyant and above the water level. The next thing would be to toss them a rope with a loop. Hopefully they're able to get the loop around them, and then you can pull that back in. I believe the next slide talks about it a little bit. If it's an ice rescue, we've already talked about hypothermia. It doesn't take very long for hypothermia to set in. So in these situations, you may not have much time before the patient's unable to assist themselves with some of these potential ways of getting them back. If you have a small flat-bottomed boat or other vessel of some sort that you can push from the rear towards the patient, hopefully if something breaks through the ice, it's going to be the bow of the boat that breaks through first. But you want to make sure that you're properly equipped with your own flotation devices. There's specialized suits so that if rescuers do enter the water, it keeps them warm. And then once you get the patient to the patient and you get the patient pulled over into the boat, you want to make sure that you have a rope tied to the bow end of the boat, and then you'll pull them back from that. Another effective tool that fire departments will utilize is to lay a ladder flat on the ice. It disperses the weight across the ice, so it's less likely that there will be a breakthrough in the ice, but it gives the ability to hopefully get to the patient, and then gives the ability to pull the patient back once you get them secured. And like I just talked about, remember that patient may not be able to do a whole lot because it does not take very long for hypothermia to set in. So make sure that you're prepared to treat these patients for hypothermia once you get them to the safe location. Always transport these patients, again, with the caveat that every patient that's conscious, alert, and oriented has the ability to refuse. But at a bare minimum, these are the patients that you absolutely try to convince into transport. Make sure that you're not working alone, because then you're just giving the potential for possibly having two patients as other rescuers arrive. So make sure that you have assistance in trying to get the patient out. It may be hard to do in certain scenarios because it'll be hard to just watch somebody potentially drown or go under the ice. But like we talked about, you have to put yourself first, and there's no sense in putting the potential for two people to go under the ice. Do not walk or run out onto the ice. Again, because of the potential, the person that's out there obviously broke through for some reason, and you don't know where the thin spots on this ice are going to be. So you potentially could break through the ice as well. So utilize one of the methods that we talked about if you're trying to do an ice rescue. Handful of slides here on high altitude illness, even though it really doesn't pertain to us here in the Midwest. Again, national standards, so we want to make sure you have an understanding of this. But basically, at higher altitudes, there's going to be less air to breathe. The air is going to be, quote, thinner. There's going to be also decreased air pressure. Now, the vast majority of people can acclimate to this, but some will not, depending on how high they go. And some people may have medical conditions that don't allow them to acclimate nearly as well. I know there was a football player, Ryan Clark, who had I believe he had sickle cell, maybe, as an African American football player. But whenever the team went to Denver, he would not play because he had had issues one time when he did play there. And so there was a life-threatening issue that he developed from playing in the high altitude. There's also a condition called acute mountain sickness, and the next slide here is going to talk specifically about that. So acute mountain sickness can commonly occur above 8,000 feet, but it can start at just 5,000 feet. Think about the Mile High City. That is going to be right at that mark. So the acute mountain sickness is the less serious case of a person experiencing problems adjusting to that thinner air. And some of these mild conditions, all that may be needed is rest and rehydration at altitude. So it may just be take them a little bit longer to become acclimated to the conditions that they put in. And more severe cases, these patients may need supplemental oxygen, and immediate descent should lead to improvement. So basically taking them out of the environment should alleviate the symptoms. Now, HACE, or high altitude cerebral edema, is the worst form of acute mountain sickness. Signs and symptoms are going to include a headache that worsens over time. They may have an unsteady gait or loss of balance and coordination. They may see signs of severe fatigue. There is also the potential for seizures, altered mental status, and potentially loss of consciousness. Now, for these patients in HACE, basically the patient care for them is going to be arranged for immediate descent. All other treatments are secondary to this. If you don't get them out of the environment, it's going to be hard to correct the issues. Administer high concentration O2, and then provide supportive treatment. So through your assessment findings, determine what issues you see, and then treat the symptoms that you do see. So that was HACE, the high altitude cerebral edema. And then there's also a condition that's not quite as serious, known as HAPE, which is high altitude pulmonary edema. Signs and symptoms of this are going to be shortness of breath, a dry cough that will eventually progress to coughing up blood, elevated breathing, and elevated heart rate. You may see a mild fever up to 100.4 degrees Fahrenheit. Their oxygen saturation is going to be lower than other asymptomatic people that are in the same environment. And remember that a person's O2 sat is probably going to be lower at elevation than it is going to be at sea level anyway. And then eventually this can lead to respiratory failure or arrest if it's not corrected. Patient care for this, again, is going to be arranged for immediate descent. Get them out of the environment. That's going to be the best thing for the patient. Administer high concentration oxygen. Minimize their physical activity. And then provide supportive treatment. Again, perform your assessment and treat the symptoms and signs that you find. And the final topic that we'll talk about here are going to be insect bites and stings. As far as insect bites and stings, all spiders are actually venomous. It's just many of them your body won't have a reaction to. But insect stings and bites can be rarely dangerous. There is the potential for anaphylactic shock to occur. So, for example, in our area here in the Midwest, bee stings are the common one that you will see from an EMS standpoint. And you may need to have your EpiPen ready because if a patient is allergic to the bee venom, then they will go into anaphylactic shock potentially, and your EpiPen is the way to correct that. With these insect bites and stings, you want to try to remove the stinger quickly. As long as the stinger is in there, it's still basically pushing the poison into the body. Once you can get the stinger out, then they're not being exposed anymore to it, and you can start treating the signs and symptoms. So what are the signs and symptoms for a patient with an insect bite or sting? It can be anything up to altered mental status. You will probably see a noticeable sting or bite on the skin, as reflected in the picture before this slide. You may see puncture marks. You may see blotchy or mottled skin in the affected area. There may be localized pain or itching where the sting occurred, and you could actually have some numbness in a limb or body part. Again, it just depends on the patient's tolerance to the venom that's been introduced into their body. And then, I mean, if you've been stung by a bee, it's going to be different if you get stung in the shoulder versus if you get stung in the finger. If you're a person that gets stung in the shoulder, you may not see any signs or symptoms other than a little bit of localized pain. But if you get stung in the finger, it may actually cause the finger to become numb and tingly. So there are some variables with this. A couple more slides of signs and symptoms that you may see here. You may have a burning sensation at the site followed by pain that spreads throughout the limb. You will probably have some redness at the site of the injection. There may be swelling and blistering also at the site. And then depending on how the person's body reacts to the venom that's been introduced, there could be weakness or collapse. There could be difficulty breathing and an abnormal pulse, or it could be something as simple as headache or dizziness. And then last slide here on signs and symptoms. You may see chills, fever, nausea, vomiting, muscle cramps. There could be some chest tightness or joint pain. There could be excessive saliva formation. There could be profuse sweating. And then finally, and the one that you need to be most concerned about, is anaphylaxis. So what's going to be our emergency care process for these situations? First and foremost, be ready to treat the patient for shock. If you know what bit the patient and you don't have a specific protocol for care, then contact medical direction. Problem is, a lot of times you're not going to know what specifically bit or stung the patient. So you're kind of flying blind. You're going to be treating the signs and symptoms and getting them to the ER so that they can hopefully figure it out. If you have the ability and you have the manpower there, it is important to try to figure out what exactly stung them, because different animal and insect bites and stings may have a little bit different treatment processes once they get to the hospital. Next thing would be to remove that stinger or venom sac. Next thing that you want to do is remove any jewelry or anything from the affected limb. In case that limb has any swelling to it, you want to get that stuff off before the swelling would get extreme enough that now all of a sudden you can't get it off and you've potentially created a tourniquet situation. There may be a couple situations, and your book talks about it, but it's in specific high-risk bites or stings from animals like scorpions or black widows, in which you may, with local protocol approval, or if you contact medical control and get their approval, where you would place constricting bands above and below the sting or bite site. if it's on an extremity but not over a joint. The goal from this is to keep the venom from spreading. And basically the bands are going to be 3/4 of an inch to 1.5 inches wide. They're not going to be tourniquets. They're going to be placed above and below the site, and you want them to be loose enough that you can slide a finger under them. So like I said, you don't want to create a tourniquet with these. And then the last thing that you want to try to do is keep the limb immobilized, and that's going to help prevent the distribution of venom to other parts of the body. And then as you go through your assessment, any signs and symptoms that you find that you can treat, you would treat those as well. So if the patient has nausea, vomiting, be prepared for those, be prepared with suction, be prepared for airway management. A little bit on snake bites here. They can require special care, but they're usually not life-threatening. So your book talks about it. There's about 50,000 people that are bitten by a snake each year. Less than 20% of those are going to be from venomous snakes, and actually there's usually fewer than 10 deaths that occur from an actual snake bite. So as terrifying as snakes are, and as scary as it can be to be the thought of being bitten by one, really more times than not, everything's going to work out okay. Again, kind of like the bites and the stings, that's not sudden unless anaphylaxis occurs. So unless that patient has a specific allergy to the venom that causes an anaphylactic reaction, that's not an imminent thing. You can get them to a hospital and they can usually take care of the situation. First and foremost is going to be to stay calm. Keep your patient calm and at rest. And a pressure immobilization bandage may be the most effective technique to slow the venom spread. Now, there are different kinds of pet snakes that people may have that are venomous, but as far as the U.S. goes, there are some in every part of the country, but there's two specific kinds of snakes. The pit vipers, which are going to include the rattlesnakes, copperheads, and water moccasins, and then the coral snakes. And even if you're bitten by one of these, doesn't necessarily mean that you're going to have the venom introduced to you. Up to 25% of the pit viper bites and 50% of the coral bites are dry bites, where they bite you, but they don't actually introduce any venom into your body. A couple slides to talk about our specific signs and symptoms. So look for a noticeable bite on the skin, which may appear as nothing more than a discoloration. Pain and swelling in the area of the bite, which may be slow to develop. So it may not happen right after the bite. It may take 30 minutes. It may take several hours. So you may have somebody that was bitten some time ago, and now all of a sudden, hours later, things are starting to bother them. They're getting concerned about it, and then they finally call EMS. You could see the potential for a rapid pulse and labored breathing. If the toxins have been introduced, this could be one of the signs. A patient may have progressive general weakness. They may see vision problems where things are kind of a dim or blurred. They may have nausea and vomiting. They may have seizures, and then they may have drowsiness or unconsciousness. Again, like we talked about, cardiac arrest and death are going to be rare in these circumstances, unless they have a specific anaphylactic reaction to the venom that's been introduced to them. So as far as the emergency care goes for a patient that's got a snake bite, first thing is going to be to call medical control to determine the best receiving facility, especially if you know the species of the snake that bit the patient, and you're in an area of the country that's prepared and equipped to deal with this. There may be specific hospitals that carry certain specific antivenom, so you may be directed to a hospital based on what the actual snake was that bit the patient. Secondly here, treat for shock and conserve the body heat. Monitor your patient, assess your patient, check their vital signs, be prepared for shock in these patients, especially in the instance that anaphylaxis may occur. Keep the patient calm. Be reassuring to the patient. Again, as with every other chapter we've taught, don't lie to your patient, but help them understand that everything's being done. More times than not, uh, this isn't going to be a bad outcome. Try to locate the fang marks. There may only be one fang mark, even though snakes have two. It just depends on how the snake bit the patient. Remove any jewelry on the extremity if an extremity was bitten. In case there is any swelling, you want to get that off before it swells and becomes constricting on the patient. If it's an extremity, keep any bitten extremity immobilized. It's going to help with pain control, and it's going to help to try to localize the venom and keep it from spreading. And then transport the patient if needed. Utilize your ALS. But just make a determination, contact medical control, kind of go from there. Final topic of the chapter here, just one slide talking about poisoning of marine life. And this can occur in a few different ways. First one being eating improperly prepared seafood or poisonous organisms, which is kind of a rarity because in the United States, it's hard to get your hands on these types of marine life to eat them. And then the second way would be stings or punctures for those that are on a ocean gulf area where they may come in contact with jellyfish, man of war, things like that. Basically, the moral to all of these are they're going to create some sort of an allergic reaction. So you're treating the allergic reaction as you would any other allergic reaction. If there is anaphylaxis, then you're going to treat anaphylaxis as you've been taught about earlier in the textbook with every other kind of anaphylaxis. So it's basically going to be the same concepts that you've already learned throughout the textbook. One thing that you do need to keep in mind is that fresh water can actually activate the toxins on the skin, increasing the pain. So if you have the ability, use salt water to rinse the affected area. Your textbook also talks about using vinegar to inactivate the venom, but you have to be careful not to introduce the vinegar into the patient's mouth or eyes. Once the vinegar's inactivated the venom, you can immerse in a hot but not scalding water to further reduce the pain. So this chapter is kind of all over the board as far as covering basically anything that can occur anywhere through the entire country. Kind of the moral to the whole thing is they're going to create some sort of reaction. You're treating the reaction. You're treating the signs and symptoms. That's going to be the end of this chapter. So kind of scroll through your chapter review here. Make sure to read the text. We'll get the test and the other packets of information up into the unit for you. If you have any questions, let us know. The next couple of units are going to be OB, and then the special populations chapters, which Marcy is going to cover both of those. And then the final unit of the EMS class here is going to be kind of the ambulance operations side of the house. And I believe Scott Melton's actually going to step in and go through some of those. So again, if you have any questions, make sure to let me know. We're working on getting another hands-on set up, so look for information being posted up on Teams as far as when that will be.